Hello guys. So everything is perfect. Audio, visual. Yes. Can somebody confirm that? Audio is good, video is good. Then we can start today INI-CET IBQ series. So PW MedEd has come up with this new series for INI-CET aspirants especially. So this image-based questions have been considered as one of the most important form of questions asked in INI-CET. Most of them, even though we keep reading continuously, we get confused with few of the image-based questions. So we have come up with this series. Hope it will be helpful for you, all the students who are appearing for the exam this year. So if everything is good, let's start the class. Yes, thank you, Ashish, for confirming that. So the first thing here is I have not come up with a whole lot of questions or a lot of images. Only few of them I have selected, and today we are going to learn them in detail, because INI-CET is one exam where you have to go in detail for answering the question. So for every topic you have to have a broad perspective. Okay, so every topic we'll discuss in little bit of detail regarding the INI-CET. Okay, so the first image, yes, I think this is one of the favorite images for the students, and they would just jump in the exam if they could see this and identify it. Yes, what is this image? हिंदी मीडियम में थोड़ा मुश्किल है बिकॉज आई एम फ्रॉम साउथ इंडिया. मेरा हिंदी उतना अच्छा नहीं है, तो यू हैव टू बेयर मी विद इंग्लिश. So what is this first image? So guys, this is an image of a very important tumor condition. So whenever I talk about IBQ, especially in case of ortho, what you have to remember is the first and foremost chapter, tumors. So this is the main important and the most important chapter which you have to read before going to the exam, right? Ashish, what is that? आपकी बात नहीं करता था. I did not understand that. Okay, so whenever somebody is talking about especially about this, especially about the IBQ, especially you have to read the tumors chapter. So this is very important, because every tumor has some representation in the radiology, and that will be asked as a question, as an image based question in the exam. So now coming to this question, so what is this? What is this tumor? Yes, I know you all can identify it very easily. So this is your fibrous dysplasia. So this is your fibrous dysplasia. So let us understand little bit in detail. So what are the topics which we are going to read in case of fibrous dysplasia, and what are that important questions which they would ask you in this exam. So first, fibrous dysplasia is a ओके. आशीष, आई कैन अंडरस्टैंड योर कंसर्न. मुझे समझ में आ रहा है कि आप हिंदी मीडियम से है और नीट हिंदी मीडियम से ही क्रैक किया, मगर अभी आप MBBS में है, तो यू हैव टू स्टार्ट रीडिंग इन इंग्लिश एंड यू हैव टू स्टार्ट अंडरस्टैंडिंग द टॉपिक्स इन इंग्लिश. ओके, so just put little effort from your side. I'll also try to match to your understanding. Okay, see, I'm not speaking something, very polished English or something like that. This is very basic English. ये कौन सी, yeah, ये कौन सी tumor hai, fibrous dysplasia tumor hai. You know, those, it is very basic English what I speak, okay? If you have any doubt, you can stop me at anywhere and ask me, okay? Till then, please try to follow, okay? Yes, so this is the question regarding the fibrous dysplasia, and now we are going to understand little bit of fibrous dysplasia in detail, because now we are going to prepare for INI-CET. So the depth of the question, the depth of the concept, they are going to ask you in detail. So first of all, tell me, there are two types of fibrous dysplasia which you have to understand. So there are monostotic fibrous dysplasia and polyostotic fibrous dysplasia. So what do you mean by monostotic? Monostotic meaning it is seen in the single bone. Polyostotic meaning it is seen in multiple areas. So whenever you come across this tumor, whenever you see this tumor, in case of good, thank you for that. So whenever you see a patient with fibrous dysplasia, you have to immediately think in mind that this fibrous dysplasia can be present somewhere else also, because this can be presented as a polyostotic form. Polyostotic means it can be seen in multiple bones. Now, can you name me any other tumor where you can see in multiple areas? So first one is fibrous dysplasia. Right, whenever somebody is talking about multiple areas, so first one is fibrous dysplasia, right? Then the second one is enchondromatosis. The second one is enchondromatosis, and the third one is osteochondroma. So osteochondroma, these three are the tumors where you see in multiple areas. So now you have to remember this, because anything when you see 1, 2 and 3, they will ask you which of the following is not. So the fourth option will be a wrong option. So now we have understood two MCQs here. The first MCQ is fibrous dysplasia. This is the image of fibrous dysplasia, and it is seen in multiple areas, which is called as polyostotic. And what are the other tumors where you can see in multiple areas? One is enchondromatosis and this is osteochondromatosis. So osteochondromatosis, what is the other name which is given to this? This is called as diaphyseal achalasia. It is called as diaphyseal achalasia. And enchondromatosis, multiple diseases, Ollies disease or Ollies syndrome. Okay. So these are the points which you have to remember. Okay. Fine. Now coming to fibrous dysplasia again. So what are the most important things you have to remember? So whenever I tell that fibrous dysplasia is polyostotic, now there are two important things which you have to remember here. So this is associated with two important syndromes, right? So whenever this polyostotic fibrous dysplasia is associated with the Café-Lutz spots. So these are Café-Lutz spots, nothing but hyperpigmented spots. These are skin pigmentation plus precocious puberty. So now this tumor, now this becomes your McCune-Albright syndrome. So this becomes your McCune-Albright syndrome. So what is McCune-Albright syndrome? Whenever you see polyostotic fibrous dysplasia with the Café-Lutz spots with the precocious puberty, this is called as McCune-Albright syndrome. Then what is the other syndrome what I'm talking about? It is about Musser-Broad's syndrome. It is about Musser-Broad's syndrome. So Musser-Broad syndrome, what is the importance you see? You see intramuscular myxomas. Right, so whenever the fibrous dysplasia is associated with intramuscular myxomas, this is Musser-Broad's syndrome, right? So M for M. And these three, Café-Lutz spots, precocious puberty, polyostotic fibrous dysplasia, is McCune-Albright syndrome. Very, very important. And this has been asked in the exam. Now coming exactly to the image. So this image is nothing but it is a deformity which has been named as a shepherd crook deformity. it is been named as the Shepherd-Crook deformity. So what is Shepherd-Crook deformity? So whenever you see a fibrous dysplasia in case of your proximal femur, it goes into a deformity. So this deformity is called as your Shepherd-Crook deformity, right? So what is actually fibrous dysplasia? So whenever this marrow cortex is replaced by the fibrous tissue. So this fibrous tissue appears as what? It appears as a ground glass appearance. So this is seen as a ground glass appearance, right? So this is seen as a ground glass appearance on the X-ray, and not to forget in biopsy. So whenever you take the biopsy, you see fibrous tissue, and this is seen as a Chinese letter pattern. On the biopsy, you see as Chinese letter pattern. So these are all the terms which you have to remember for your fibrous dysplasia. So there are two important syndromes: McCune-Albright syndrome, Mazur-Brod syndrome, your capillate spots with precocious puberty, your Mazur-Brod syndrome. And what is the important thing here? This is nothing but your Shepherd-Crook's deformity. So what is Shepherd-Crook? It is something like this, right? A stick where the shepherd uses. Okay, so that is called the Shepherd-Crook deformity. And what I want you to still remember is, so the story is not still ended here. So okay, so these capillate spots are considered as coast of main. So these capillate spots are present as coast of main. So what is this coast of main? Coast of main is whenever they are present with the rough borders, right? So whenever they're present with the rough borders, rough edges, that is coast of main, and coast of California is smooth border, that is seen in neurofibromatosis. Okay, so this is about your fibrous dysplasia. Is that clear? So how do you treat it? So what is the treatment? They might end up asking the treatment also. So treatment, usually the patient presents with the pathological fractures. So you treat them with the fixations, right? Treat them with fixations, sometimes with the prophylactic fixations, right? So this is about the fibrous dysplasia. Clear? Yes? So this is about all the things which you have to remember. See, now the question might be about the coast of main also. They can just ask you, what is this coast of main? Okay, so these are the pigmented spots, the capillate spots which are present in the form of coast of main is seen in case of fibrous dysplasia. So this image can lead to a question of that. This image can lead to a question of, what is Mazur-Brod syndrome, what is McCune-Albright syndrome. So how does it looks on biopsy, which pattern, the Chinese pattern, on X-ray, the ground glass appearance, right? And the deformity is called the Shepherd-Crook deformity. Is that fine, everybody? Yes, so that is about your fibrous dysplasia. Okay. Next question. So next image-based question. So what is this? What is this image? So this image is about a, yes, this image is about the splint. So this is called the skin traction, or the other name is given as the Buck's traction, right? So what is actually this? So this is a skin traction or the Buck's traction. So where actually we use this? So here this is mainly used for your hip fractures, right? So whenever you have a hip fractures, these are the proximal hip fractures, especially your IC, IT, and your subtrochanteric fractures, right? So this is the Buck's traction apparatus, where you see you have a foam like this, right? So this is a crepe bandage like thing, and these are the padded things, this one. So you have to put the two pads and then you are tying up with the crepe bandage. So why do you do this? This is mainly for giving traction. So why traction is given? It can be sometimes to decrease the pain, sometimes to correct the deformity, right? Sometimes to correct the deformity, right? So how do you give this traction? So this is given as not more than 3 kgs. So this is called skin traction. You have to give not more than or equal to 3 kgs, right? So depending upon the patient's body weight, sometimes you can increase up to 3 to 3.5 kgs. So here you will hang the weight. So this is where you put the weight, right? So this is where you put the weight. So sometimes, you know, to if a patient needs any further investigations, you know, to buy time for surgery, so you can just put this skin traction to the patient for immobilization. And for immobilization. So these are the certain indications where we use this traction, but nowadays usually we are not, most of the time we are not using. Usually we use in the night times where the patient arrives to the casualty at, you know, by 10 11 and case is posted in morning 6 o'clock 7 o'clock. So just to make them feel, you know, just to release that pain by the traction, we can use this. This is called the skin traction apparatus or the bucks traction, mainly used in the hip fractures. And what you have to do, this particular part, whatever the traction you're putting, this particular part you have to put a pillow here. So a pillow is placed like this, but the heel part is usually free. Heel is usually free. You have to leave the heel part. Heel is usually free because there should not be any compression over the heel. So you are not going to compress the heel like this. They might develop sores, okay, skin sores, by putting pressure on that particular area. Okay, so those are some of the pressure points. That heel is pressure point now. So you will put the pillow up till the here. Leave the heel part is usually left free, and now you hang the weight to it. So usually we go up to 3 to 3.5 kgs can be used depending upon the patient's weight. So this is called the skin traction or the bucks traction. Okay, clear? Yes, any doubts? Okay, now this is skin traction, you all understood. Now what is this? What is this apparatus called as? So you can again see there is a pulley, there is a weight, there is a cord, right? So what is this apparatus called as? So this is called as the, yes, very good. This is called as the Bowler-Brown splint. Yes. This is called as the BB splint. Very good. So this is the Bowler-Brown splint, right? So this is the Bowler's-Brown splint. Very good, Gautam. So this is Bowler-Brown splint. It was asked recently in one of the exams, right? And what is the specification of this Bowler's-Brown splint? So now what you have seen, the before image was a skin traction. So we are not using anything else except we are just putting a crepe bandage around the limb, and we are using the skin somehow as the traction. So here what we use, we use the help of the skeletal traction. So we use the help of the skeletal traction. So how do you do this? This is called UTPT, upper tibial pin traction, right? So upper tibia or the proximal tibia pin traction. So this is most common area where we put the pin. So you can see here, so whenever there is a fracture in the femur, so usually this is used for femur shaft fractures or subtrochanteric fractures. So femur shaft fractures or subtrochanteric fractures, this is used. And how it is used? We use the help of the pin. So this is your upper tibia. So now I am going to place a pin from proximal tibia like this, right? So this is the pin. How do I place it? I place it from the lateral to medial side, right? And we can use the pin in upper tibia. You can use it in the lower tibia as well. Calcaneum or distal femur. So these are all the areas where you can put the pin, right? You can put in the upper tibia. Usually we prefer upper tibia for femur fractures, or sometimes if the fracture is so proximal, we can go for distal femur pin traction also. So whenever you put the pin, you take care about the arteries and nerves around it, and you use the safe zones. So we have certain safe zones for each pin which are not necessary for you. So these safe zones we take care, and then we put the pin. What is important for you is the name of the splint, that is Bowler's-Brown splint, and how do you do this? So what are the things which are required for you? So what all you need? You need a Steeman pin or a Dunham's pin. You need a stirrup, which is also called as the Bowler's stirrup. And then you need the BB splint, right? And then you need the weights. So these are the things which you need. So how much is the weight? You can go up to 10% of the body weight. So 10% of the body weight you can use, right? And now this Bowler splint, what I'm talking about, has 3 pulleys, right? So this has 3 pulleys. So 1, 2, and 3, right? So here you can see there are 3 pulleys like this, and depending upon the patient's condition, we use the pulley. That is also not exactly necessary for you. Just remember there are 3 pulleys which can be used according to the patient condition. So for femur fracture, we use 1 pulley. And then for foot drop pulley also is there, where you can put the foot in the neutral position, right? So these 2 are the pulleys, and the third one is for the alignment, directly to the leg alignment, right? So these are the 3 pulleys which are present, and now the weights are hanged through this pulley, right? So these are the things which you need. So this was asked in the exam. So what are all the things which you need? Steeman pin, Bowler stirrup. So this is your stirrup, right? So you put the pin, attach the pin to the stirrup, then you attach this to the cord like this, the string, and then you add the weight. So how much weight? It should be 10% of the body weight. The maximum weight which we can use is 10% of your body weight. Where do we use it? We use in the femur shaft fractures and subtrochanteric fractures, that is especially in the lower limb fractures. Where else we can put the pins? We can put the pins in upper tibia, lower tibia, calcaneum, and the distal femur. So these are the pin sites where we can put, right? Is that clear? So this is about your skeletal traction. So this was your skin traction, and this is your skeletal traction. Fine? Yes. So next one, what is this? Identify this splint. So again, the next important thing after tumors, after your splints. So whenever somebody is talking about IBQs, so splints are very, very important, right? Then I've told you these are the tumors which are very, very important, right? And then comes the instruments. So these are the 3 areas where we have to cover while, reading your IBQ. So what is the splint? Yes? Yes, Gautam, go ahead. What is this? Identify the splint, very, very important. Not sure. Okay. So this is a Taylor's splint. So this is your Taylor's splint. So what are the splints? So splints or orthosis. There are two important things. Splint or orthosis is one which is helping you, it will replace your, it will functionally help in, that particular part. For example, if you're taking a cervical collar, that is a type of cervical arthrosis. So it will give support to the cervical spine. Right. And what is the splint? Splint also is one particular thing, or one particular it is like a type of, cock-up splint, knuckle blender splint. So these are the other, again, they will support your body. They support the body part and help you. Sometimes even they can help you functionally also. So this is called the Taylor's splint. So this Taylor's splint mainly covers the thoracic, lumbar areas. So it mainly covers the thoracic, lumbar areas, and it is especially important for the thoracolumbar region. So what is the thoracolumbar region? Especially that region which covers from T10 to L2, right? So usually we see the TB, tuberculosis. So this is very, very important Taylor's splint, which is used in a condition which is called as tuberculosis of the spine. So tuberculosis of spine, which is also called as the Pott's spine, right? And in that, especially the thoracolumbar region is the one which gets affected. So to support that particular area, this splint or brace is used. This is called the Taylor's brace or the splint, right? So this is the brace. So Taylor's brace or Taylor's splint is nothing but it gives support to the thoracic and the lumbar region. Is that clear? So this is your Taylor's brace. Okay. So this is mainly used for tuberculosis of spine, and sometimes it can also be used for fractures of spine, especially again your TL junction, that is thoracolumbar junction fractures, right? So these fractures, whenever we read conservative treatment of the fractures or post-operatively, you can use this Taylor's brace. Okay, so this is your Taylor's brace. Very, very important question, right? So once have you understood this Taylor's brace, there are two important brace which you have to understand. So the first one is called your Milwaukee brace, right? And the second one is called your Boston brace. Milwaukee brace and the Boston brace. So where are these two used? These two are used in a condition which is called as scoliosis. Yes, very good. So one A is your Milwaukee brace, B is your Boston's brace. So if you see Milwaukee brace, it is extending up to your chin, right? It is supporting your chin also here, this area. And Boston brace is mainly again your thoracolumbar. Right, this is mainly a thoracolumbar. This is, yes, it is mainly used for a condition called scoliosis. So what is actually scoliosis? So there would be sideward bending. Yes, previous IBQ that was for FMG students. Yes, this is specifically for the INI-CET students. If you want to watch, you can still watch it. Otherwise, you can refer to that particular class if you're preparing for FMG. So what is scoliosis? Scoliosis is sideward bending. So there would be some discomfort, some abnormality or some deformity in the spine, and that will result in a condition which is called as scoliosis. And in scoliosis, what is the angle which we measure? Angle which we measure, which is called as Cobb's angle, right? So this Cobb's angle is measured to understand the treatment. Yes, very good. So whenever it is less than 20 degrees, you observe the scoliosis curve. If it is 20 to 40 degrees, you prescribe orthosis. So what is this orthosis? I told you this is a support which is given to that part. And if it is more than 40 degrees, you go for surgery. Right, you go for surgery. Very good, Bharat. So Cobb's angle. So Cobb's angle is used to measure the scoliotic curve. So scoliotic curve, it is something like this. So we measure that curve and we give the angle to the patient, right? So this angle, whenever it is measured, so if it is in this 20 to 40 degrees, we use the orthosis. So what are the two braces which we use? If it is cervical scoliosis also, we go for Milwaukee brace. If it is thoracic and lumbar, we go for Boston brace. So these are the two important braces which you have to remember. So this is the Taylor's brace, this is Milwaukee, and this is your Boston's brace. So these are the three important braces you have to remember for your spine, right? And now this was asked in the exam. So now what is this? Identify this. Is this Milwaukee, Taylor's brace, or Boston brace? Which one is this? Very good. It is Milwaukee. So this was exactly the image which was put it in, which was given in the exam, right? Which was given in the INI-CET exam. So sometimes you have to identify, based upon the image. So whether it is extending up to cervical or it is extending only up to thoracic. Okay, so this is extending up to cervical. The mandible also is involved. So this is called the Milwaukee brace, right? Very good. Next image. So what is this? Yes, this is used for very good. This is public harness. Yes. What is public harness? So this is public harness, and yes, this is used in a condition which is called as developmental dysplasia of hip. That is your DDH. What is developmental dysplasia of the hip? So this is a condition usually seen in the newborns, and there are certain characteristic features for the mother. For example, if the baby, sometimes if it is a female, if it is a firstborn, and if it is in breech position, right? And sometimes if oligo is associated with it, right? Sometimes if there is a twin pregnancies or multiple pregnancies. So these are all the risk factors for developing this condition, which is called as your DDH. So what exactly happens in DDH? So there is a problem. There could be acetabular dysplasia, and the head gets dislocated. Head gets dislocated. So how do you identify? So you identify this by doing two screening tests. So what are the screening tests? First one is your Barlow's test. Yes, and Otterloni. So these only are the screening tests. No, not Alice test, Galeazzi's, these are not screening tests. Okay. When I asked you particularly screening test, you have to name only these two. These are the provocative tests. So Barlow is a provocative test. So you're bringing the head outside. So that is Barlow's test. Okay. And now when the baby starts walking, then you have all your Galeazzi tests, your Klissick test, right? And all those, your Klissick sign. Okay, so but the screening tests are two, Barlow's and Otterloni, and these are the risk factors. So if it is a female firstborn breech positions with oligo and twin pregnancies, so it is usually seen 20%, usually it is bilateral. Okay, 20% it is bilateral. And what is the incidence? 1 in 1,000 live births. 1 in 1,000 live births. I've told you INI-CET is little in-depth questionnaire, it will be there, so you have to remember all these things also. So 1 in 1,000 live births is the incidence, and 20% present with bilateral. And what are the risk factors? The female firstborn breech position. In this too, if you want to select one important thing, the breech position is supposed to be one of the most important risk factor, right? Clear? And what are the two screening tests? One is Barlow's and second one is Atterloni, right? And what actually happens in DDH? So there will be some problem in the acetabulum or the head or the labrum or the ligaments around the hip joint, and now the head gets dislocated. So how do you treat it? So what is the treatment for it? So the treatment for it is up to 6 months. What you do? You treat it with this splint, which is called as your Pavlik harness. So what is the position which we are giving? The position is abduction. The position is abduction, right? So you put the baby's position in the abduction. If you see, this baby limbs are abducted like this. And this is one of the reason in Asian countries, it was, especially in our country, in India, it was, the incidence of this is very, very low, because we have this habit of carrying the babies on the hip, right? So whenever we carry the babies on the hips, the mother carry the babies on the hips, we put the hips in the abducted position. So this is your abducted position. So how do you put the Pavlik harness? You put the abduction position, right? So that is up to 6 months. When the baby comes to you and you identify up to 6 months, you have to go for Pavlik harness. So once it is after 6 months, you can try closed reduction plus hip spica. So what is hip spica? Hip spica is, again, we use POP. The plaster of Paris is used, and we'll completely put the two limbs in abduction. So what is closed reduction? So you know what is DDH? DDH is, there is some abnormality in the hip and the head has gone out of the acetabulum. Now you reduce the hip. You do the maneuver and you reduce the hip. Okay, and then after that, if you're not able to reduce the hip, then you go for open reduction, and then you put the hip spica, right? And if the baby is more than 3 years, then you have to go for osteotomies. So there are various osteotomies. So that is, what are the various osteotomies? Osteotomy is nothing but, now what happened? Now the head is completely outside the acetabulum. And if you see, after 3 years, baby has already been walking, and all the development has been completed. Right. So now what you do? You do osteotomy. So you have to do a certain very complex surgery where you are going to put the acetabulum. Like there are certain osteotomies, you can go for pelvic osteotomy or femur osteotomy. So pelvic osteotomies are certain. So as we are preparing for INI-CET, I want to name them also. So we have names of that osteotomy. Just remember the names. We got the Chiari's osteotomy, Pemberton osteotomy, right? Chiari's osteotomy, Pemberton's osteotomy. These are the pelvic osteotomy. So you will do certain modifications to the pelvic bone, and now you make it as acetabulum, right? Salters. So these are the 3 important osteotomies which you can remember. Just remember the names if you want. Chiari's, Pemberton and Salters osteotomies, right? And then if the baby is more than, in the teens, then obviously he has to go for total hip replacement. Total hip replacement. So this is the treatment criteria for your DDH. So if it is 6 months, 6 months to 1 year, maybe you have to consider. This is 1 year to 3 years, more than 3 years, right? So this is the treatment protocol for baby with DDH. Okay. Is that clear? So now you will identify this is the Pavlik harness, and now they might ask you anything related to this. So they can just put up, identify the splint, or they can ask you what is this position, is this adduction, abduction, or what is the treatment. So you all know that treatment is abduction, and they can ask you what are the risk factors for affecting this baby. So female firstborn, breech, oligo, and twin pregnancies, and they might ask you what would be the screening tests that have been done to the baby to give this treatment. So these are two important screening tests, Barlow's and Acharlani. And then they can ask you any treatment protocol. Now, if the baby is presently put in the splint for 6 months, and now after 1 year, if the baby comes to you, what will you do? So you will try for reduction and then go for hip spica. If the baby comes at 3 years of age, you will go for, remember, osteotomies. And if it is in the teenage, and if it is, advanced like 12 years old, 13 years old, then you go for a total hip replacement. Okay. So that is about the DDH, developmental dysplasia of hip. Okay. Okay, now what is this? Yes. What is this condition? Very good. So this is the Gunstock deformity, and I want Gautam to correct it. So Gunstock deformity, very, very important. This is a, what is this? This is a fracture complication. This is a fracture complication. So what is that complication? So there are two important complications for the fractures to unite. One is non-union and malunion. So what is this? Is this a non-union or a malunion? Okay. Fallen outstretched hand. Okay. What is this? Is this a malunion or a non-union? Bharat? Very good. So this is a complication of malunion. Of which important fracture? Supracondylar fracture humerus. Yes. So this is one of the most important fracture which you have to remember, and it is usually seen in the age group of 4 to 8 years, right? Yes, supracondylar humerus. So 8 years, and it is an extra articular fracture. Sometimes it can involve the Salter-Harris type 2. Right? Salter-Harris type 2 fracture. So Faisal injury can occur. It belongs to Salter-Harris type 2, right? And then what is important is it is a result of a malunited fracture. It is a result of the malunited fracture. And what is this? This is cubitus varus. Okay. Your Gunstock deformity or your cubitus varus. Okay. And now, how do you treat it? So let's complete this cubitus varus. So treatment of varus is you again do a osteotomy. That means you correct it, alignment. Whenever you want to align the bones, you cut the bones, right? So osteotomy, and the name of that osteotomy is your French osteotomy. So this is a wedge-shaped cutting which we do. It is like this. The bone is cut in the shape of wedge like this. Okay. So this is called the French osteotomy for the treatment of Gunstock deformity. And this is the cubitus varus. And it is mostly seen in your supracondylar fracture humerus. And now what are the other complications where you see in this supracondylar fracture humerus? So which artery is involved? Yes. Most common artery which is involved in this fracture? Yes, that is your brachial artery. And nerve? Anterior median nerve, more median, then radial, then ulnar. Right? Yes, very good. Brachial artery injury, AIN. And what is the one more important thing which we can see in this? VIC. Whenever your brachial artery is involved, it might result in Volkmann's ischemic contracture also. Right? And not to forget your compartment syndrome. So these are all the complications of supracondylar fracture humerus. So they might result in brachial artery. So whenever the artery is involved, it might result in Volkmann ischemic contracture, that is VIC, or sometimes the patient may present with compartment syndrome, or the arteria, brachial artery, the nerves is the AIN nerve which is involved. And this is the cubitus varus deformity, right? That is called the Gunstock deformity. Is you seen in the supracondylar fracture humerus, and the treatment is French osteotomy. And whenever you talk about supracondylar humerus, if they want to talk in terms of Salter-Harris classification, so this Salter-Harris classification is for your physeal injuries, right? So supracondylar will fall in the type 2, where the metaphysis is involved, right? Thurston, hole and fragment metaphysis, right? Yes. That is about the Gunstock deformity. What is this? Yes, Thurston, hole and fragment, not sign, fragment. So the metaphysis fragment is called the Thurston, hole and fragment. And again, I have told you IBQ is again equal to tumors, splints, and then comes your instruments. So not to forget, you have to have a look about all the instruments and go. Be it your surgical instruments, orthopedic instruments, gynec, anything. Okay. So what is this? What is this instrument? Yes. You're asking me, Gautam, is it a bone nibbler? No, it is not. Bharat, where have you gone? Dr. MTG? This is not bone nibbler. So this could be a, you can see a clamp like thing. So this is the clamp. So this is a bone holding forceps. Yeah, I know. So this is your bone holding forceps. Okay. So what is a bone holding forceps? So if you see this, just imagine now I'm holding it this way, right? So these two clamps, they will hold the bone here. You can see the serrations here. So these serrations will hold the bone, and once they hold the bone, you will lock it. So this is called the AO clamp. This is called the AO clamp. So there are various bone holding forceps. This is AO bone holding clamp, right? So whenever you hold the bone, so why do you want to hold the bone? You hold the bone because you want to reduce it. So when we deal with the fractures, what do? We put two bone holding forceps to two fragments, right? So for example, if this is a bone and this is a bone, now this is a big bone and it has been fractured. Now you put the clamp here, one bone holding forceps and another bone holding forceps, right? So this serrations will hold the bone, and now you try to reduce the bone. So once you reduce the bone, what you do? You put the plate over it. So this is the plate, right? Once we reduce the, so now what we have? We even have the plate holding forceps also. We have the plate holding forceps, right? They are different. I'm very bad at drawing, so excuse me for that diagram. Plate holding forceps. This is bone holding forceps, right? And 1 second, I want you all to see some of the instruments I want you all to remember. So this is the first one. So this is your periosteum elevator. So what is this? So MTG, let's make an attempt to identify few of them, okay? So this is your periosteum elevator. So why you want a periosteum elevator? Again, if you go back to our basics, so I told you this is the bone and this is the bone, right? So now you're going to put the plate here. So you are going to clear this periosteum. So bone, what is a periosteum? It is a thick layer which is attached to the bone. So now what you do, you just scrape that little periosteum, so that you want that rough surface, because periosteum is little slippery. So you will scrape that periosteum. So how do you do that? You use this periosteum elevator. Okay. So the first one you have to remember is periosteum elevator. Then the second one, what is this? These are the bone levers. These are the bone levers. So you have to levering the bone. So for example, if you are not able to reduce it properly, if the bone has gone somewhere, you know, inside the muscle or inside the fascia, to levering out the bone, you use this bone levers. What are these? These are the bone spikes. So if you see, these are the spikes. Exactly, you can have that. So these are the bone spikes. So once you identify the bone, so these are the steps of fracture reduction. So now what you do? So now what you do? You cut the skin, then you cut the fascia, then the muscle, you remove the muscle, then you remove the periosteum. So once you have identified the bone, what you do? You put this bone spike here. Right? So you use the two bone spikes like that, and now you identify the bone, right? So these are the bone spikes. So remember, there are spikes, there are various, this is the small spike, this is the broad spike, like that. All are spikes only. This is a smaller spike which is used for, you know, radius, the smaller bone, and this is the medium spike. Okay, so these are the spikes. Then this is the bone nibbler. So Gautam, see, this is the nibbler. So you will have this mechanism for the nibbler. So it is like picking. So it is not the clamp. You don't clamp. So it just like that, you have to hold the bone and pick it up like that, right? So this is the mechanism what you have there. That is your bone nibbler. And the second one is bone cutter. So this is the sharp edges we have. So for cutting of the bone. So this is the bone cutter. This is nibbler and this is bone cutter. Okay. And then this is very, very important. This is nothing but your osteotomes. If you see, these are your osteotomes. So very sharp edges. What you have to remember is the edges are very, very sharp here. And now you put why do you use this osteotome? You put the osteotome over the bone and then you try to cut the bone. For example, malunion. For example, malunion, you have to break the bone, right? So for that, you use this osteotome. Yes, very good. So this is your osteotome and this is your chisel. So this is the chisel, right? These two you have to identify. Osteotome is very sharp like that. And chisel has somewhat beveled edges like this, right? So that is your bone osteotome and chisel. And then, so this is the difference. I have put two together so that you can identify. This is your osteotome where you have a very sharp edge, and this is your chisel where you have a beveled edge. Beveled is something like this, right? So that is bone, chisel and osteotome. This is the mallet. So for chiseling and osteotome, both you have to use the mallet so that you can break the bone, right? And then this is your curate. Curate is for removing all the hematoma or clearing the fracture ends or removing the tumor. So this is your curate which we use, right? And this is your bone gauge. This is for bone graft. So once you want to collect the bone graft, then you can use this bone gauge. Okay. And now these are your bone clamps, what we were talking about. So you have various clamps. So this is one clamp, this is one clamp, this is one clamp. So I was telling you about the AO clamp, right? AO is nothing but which has been a group of orthopedic surgeons have formed an association, right? So that is AO, and now this is the AO clamp, and this is the bone holding clamp, and similarly this is a plate holding clamp. If you remember, yes, also it is used for debridement also, the curettage, yes. And this is the plate holding clamp. I told you, right, once you reduce the fracture fragment, you have to put the plate, and now this plate you will hold with the plate holding clamp, right? So these are some of the instruments which you have to remember. Done. Okay, hope you will remember them. Just revise them before going to the exam. So what are those important things? First, you should always have a look at the osteotome. Then they will ask you about bone nibbler, right? Then they can ask you about spike, bone spike, right? And osteotome or chisel, right? Osteotome or chisel, bone nibbler, bone spike, bone holding forceps, and curettage. Curate. So these are certain important things. Just before the exam, you're going to have a look and go, right? So that is about the instruments. Now what is this? So this was a very important question which was asked in the NEET. So this is for the pelvic trauma. So this is considered to be one of the most important emergency. And the first step, what we do? First step in pelvic trauma is identify patient in shock, right? And then use a pelvic binder, right? Very good. So this is the pelvic binder. But at which level you put this pelvic binder? So there is no pelvic binder available, and you are at some, remote areas where pelvic binder is not available. Then what will you do? What will you do? You use a big bed sheet. And where do you put this? At the level of greater, yes. And you put at the level of greater trochanter to close the pelvic ring. If you remember, the pelvic is a ring-like structure, right? So you have to close this pelvic ring to avoid excessive internal bleeding. So this is your pelvic binder, right? And now they have asked about pelvic binder. This time they might ask you at which level this is usually put. So not to forget, it is at the level of the greater trochanter. So identify both the greater trochanters on each side, and then you apply around it. So you will put a big bed sheet and tie that bed sheet tightly, so that now you're closing that pelvic ring. So this will control the bleeding, right? And one more important thing what you have to do in the pelvic cases is you have to analyze the patient regarding the shock. So for that, what you have to see, you have to check for the BP, the pulse, and then the urine output. So these three are very, very important. And then send for cross matching, right? Sample should be sent for cross matching. Blood grouping and cross matching should be done, right? So this is very, very important whenever we are dealing with pelvic trauma. And once you put the pelvic binder, then you can send the patient for imaging, right? It's like X-ray or CT scan. So that is about the pelvic binder. Next, what is this image? So this might take a little time for you because I have not put the bilateral image, only single image I have put. This is the image of the X-ray of the shoulder joint. And this has been same asked in the INI-CET November. Last exam, right? So what is this? So if you see, if you can identify, this is the head And now this is your clavicle lateral end, right? Sorry, this is the clavicle. Clavicle lateral end. And this is your acromion. Which dislocation? Which dislocation? Yes. So this was being asked, the same image. This is AC joint dislocation. Yeah, Gautam Prakash, it is AC joint, acromioclavicular joint. Yes, coracoacromial also is correct. So this is the AC joint dislocation. So now this is the one of the not very frequently asked question. It was not a PYT, also a new question which was asked. So don't always think that only PYTs and PYQs will help you. You have to have an overall knowledge, right? So this was been image which was put in the exam, and if you see the difference, you know, this has to be together like this. AC joint. But now because of the disruption of the ligaments, so what are the ligaments which have been disrupted here? AC plus CC, acromioclavicular plus coracoclavicular ligament. So there is a ligament disruption, right? Yeah, claviculoacromial, very good. So these are the two important ligaments, if you see. So acromioclavicular ligaments are present between these two, and there are coracoclavicular ligaments also. So these are coracoclavicular ligaments. If you remember, go back to anatomy, there are conoid and trapezoid. These are two important ligaments which are present, and AC are the ligaments which are present, and there is a capsule also like this. So whenever there is a injury, so usually what happens is the patient will have adduction injury. So whenever there is an adduction injury, first there will be AC ligament followed by CC ligament damage. So whenever there is damage of this, first AC followed by CC, right? So whenever there is a damage to these two ligaments, what happens is the clavicle seem to move upwards, right? But actually what happens? Shoulder falls inferior because of gravity, because the suspensory, if you see, this is only suspended, this limb is suspended by the clavicle, right? The AC clavicle, the acromioclavicular ligaments are very, very important, The acromioclavicular ligaments are very, very important for suspension of your upper limb, right? So once these ligaments are disrupted, so the acromioclavicular ligaments and the coracoclavicular ligaments are disrupted, what will happen? It will result in your complete shoulder joint going down. Because of gravity, it is pulled down. So that is why you see that there is a pulling of the shoulder joint downwards and the clavicle is moving upwards. So this is your AC joint dislocation. Right? And now what I'm interested is, what is that view, important view which you have to remember to identify this? So that view is called the Zanka view for AC joint. Remember Zanka view, right? So they might ask you the view also. So this is the AC joint. We have to visualize on the both the sides. So Zanka view, you get the bilateral AC joints, right? And then you can identify the measurement also, CC measurement, coracoid clavicular measurement also you will see, right? So remember adduction injury. So the shoulder adduction, shoulder goes into adduction like that, and then there will be damage to your AC joint. And this is the image which usually the patient presents with pain in the shoulder. Okay. Anything else you want to know about this AC joint? So there are 3 grades. Grade 1, 2, 3. Right? 1 is a mild injury. 2 is AC ligament disruption. 3 is AC plus CC ligament disruption. Right? So this is the grading for grade 1, 2 and grade 3. Okay? So that is about the AC joint. And the view which you have to remember is the Zanka view. Okay? Yes. Next, what is this? Yes. What is this test? This is a very, very important test. Frequently asked. This is called the Thomas test. Thomas test. So why do we do the Thomas test? Thomas test is done for identifying the fixed flexion deformity. Yes, very good. Fixed flexion deformity of the hip. So you have to identify the fixed flexion deformity of the hip. Yes, very good. For what is a fixed flexion deformity? That means, what does that mean? Simple. No extension of hip. So the hip extensors are not working. So then now the hip goes into fixed flexion deformity. So how do you identify this fixed flexion deformity? So we identify this by doing a test which is called as the Thomas test, right? Not get confused with Thomas splint. We have Thomas splint, we have Thomas collar. This is the Thomas test. Okay. And now how do you do this? So this Thomas test is done by putting patient in supine position on hard couch. That you have to remember. So why hard couch? Because here when you put on the hard couch, the patient lordosis is seen, right? So once the patient is lying on this bed, you check for the lordosis. Check for lumbar lordosis, right? You check for lumbar lordosis. And now what you do? Now you flex the opposite hip until the thigh touches the abdomen. Right? So these are the steps of the Thomas. This has been asked in the exam. INI-CET, the same thing was asked in the exam. What are the steps? So first, patient in supine position, you check for lumbar lordosis, then you flex the opposite hip until the thigh is touching the abdomen. And now what you do? Now once your thigh touches the abdomen, what happens? Now you can measure the flexion deformity of affected hip. Right? So now this is the flexion deformity. So now you can see. So now what happened here? This was normal before. Before he was touching this, before doing this maneuver, you can see this is normal. Right? So once he is flexing the hip completely, once the opposite hip is flexed completely, what happened is there is a flexion deformity. Now how do you measure it? So now you measure this by goniometer. So you measure this by goniometer. So what is that goniometer? So goniometer is nothing but it is something like this. So there are degrees here. Okay. And this is like a scale type, like this. So what you do, you take these two scales, right? And now one scale you put it on the couch. Second scale you put along the femur. And now this particular curve shape is there, no? This will come like this. And now because of this angle and this angle like this. So one scale to the couch, one scale along the femur. And now you can measure the degree. So this is your FFT. So how much degree you get? 30 degree, 20 degree. This is your fixed flexion deformity of hip. So there will be 20 degrees of flexion deformity. That is how you do the Thomas test. So this is how you do the Thomas test. So steps has been asked in the exam. They have put A, B, C and D and they have jumbled it and they have asked you to put it in the order. So this is the concept behind your fixed flexion deformity. So what you do, you put the patient on the couch and first you check for the lordosis, then you flex the opposite hip. Opposite hip, when you flex, you can see there is some deformity which you can create in the affected limb, and this deformity is measured by goniometer, where you place the two different scales and you measure it, right? So that is your fixed flexion deformity of the hip. So what is fixed flexion deformity? So whenever your extensors muscles, like what are the extensors of the hip? When the gluteus maximus muscle is involved because of any deformity, like your any disease like your tuberculosis, your avascular necrosis, so the extensors become weak. So whenever the extensors become weak, the hip goes into flexion. But with the flexion of the hip, can you walk? You can't walk, right? With the flexion of the hip. So what the body does? The body compensates with increasing the lumbar lordosis. So now what you do? You make the patient sleep straight on the couch so that the lumbar lordosis becomes straight. And now because you're making it straight, your fixed flexion deformity is coming out. So that is the theory behind your Thomas test. I know it is a little bit excess for you, but sometimes they will ask in the exam. Okay, only for the exam purpose you have to learn. Okay, so that is the Thomas test. Now what is this? This is easy now. Once we are done with the harder part, now comes the easy part for you. Very, very important. Very good, Gautam. So this is your very important, very favorite giant cell tumor. So I don't know, so much liking towards this tumor for many of the examiners because it is one of the most common tumor. So this is supposed to be a benign tumor, but an aggressive tumor, right? So why it is called aggressive? The aggressive nature is mainly because of its recurrence. And I know you know everything about this osteoclastoma, all the E's. So this is epiphysis in origin, eccentric, expensile. So these are the three E's which I want you all to remember. The eggshell cracking, not very, very important, not to waste your space in the brain. So just remember epiphysis, eccentric, expensile. This is very, very important. This you have to remember, right? And yes, the appearance which you see on the X-ray, this is called the soap bubble appearance, right? And now what is seen on the biopsy? So you take the biopsy. Yes, I want something on the biopsy. Biopsy, we take the biopsy and what we see? We see giant cells, right? giant cells are seen on the biopsy. Very good. So that this will be asked in the exam. So now INI-CET, what they will do, they will give this X-ray and they will ask you what actually you see on the biopsy. So you see a giant cells on the biopsy, which is very, very important, right? And then they might ask you the treatment. The treatment is extended curettage. What do you mean by extended curettage? So extended curettage is nothing but we use certain adjuvants. We use certain adjuvants. So now what you have to do? So recent advancement for GCT, what you have to remember is they are trying denosumab also. Treatment. This is a recent article which has come up in the treatment of your GCT. This has been not asked in the exam yet. So INI-CET people are very, very intelligent and they will ask you this. So which drug is nowadays given in GCT? So remember denosumab. Denosumab is being tried treating GCT. Why denosumab is given? Because it makes the GCT a little bit smaller. So if it is so expensive, no, so it reduces the size so that you can scrape it out easily, right? So denosumab is used. Yes. Rank ligand, yes, very good. So it is also called as osteoclastoma because of this giant cell nature. Osteoclast. Yes, and now what is the adjuvants I'm talking about? So what is the treatment for it? So now we are going, we told that they had been treated with denosumab, and now once you finish the treatment with it, the treatment is always surgical. What you have to go, extended curettage. So what is extended curettage? Now you go open the wrist, because this is in the wrist joint. You open the wrist joint, you will identify the tumor part, you will curate. Curate is entire mass of the tumor you will remove, right? So once you remove entire mass of the tumor, you know that this is a very aggressive tumor. That means there is a recurrence. So to avoid that recurrence, what you do, you fill it with bone cement. So bone cement is polymethyl methacrylate, PMMA, polymethyl methacrylate. So this bone cement, what it will do, it will produce the heat. So this heat will kill the tumor cells, right? So that is why we use the bone cement, or you can use the liquid nitrogen. Same, again it will kill the tumor cells, right? So bone cement, liquid nitrogen, or anything extra we use after curating is extended curettage. Is that clear? So that is about your GCT. Anything extra you want to ask? So that is about the GCT, right? Next, what is this? Yes? I want everybody to answer. Very, very important again. Rajan, there is one more name specifically given to it. Yes, this is CTEV only. What is that? Morgan? Gautam, it is Dennis Brown. It is the Dennis Brown splint, DB splint. Yeah, the Dennis Brown, very good. So what is this Dennis Brown splint? So now we have to talk about CTV. What is CTV? Congenital talipes equinovarus. Yes, I know. And what are the deformities? So the deformities are cavus, adductus, varus, equinus, right? So this is all the deformities which we see, right? Cave, very good. Gautam, no need to feel sorry. It is okay. You have to make mistakes. Then only you will remember. Okay? Nothing to say sorry. No need. So cavus, adduction, varus, equinus. Okay. So these are all the deformities which you see in the foot, right? So where do you see this cavus? Cavus we see usually in the midfoot, right? That means the arch of the foot has been increased. Adductus we see in the forefoot, right? Varus where we see in the hind foot, and equinus in the ankle, right? So this is congenital. Congenital means it is by birth. Talipes. Talipes. Tali matlab foot. Sorry, tali matlab ankle. Pes is foot. Now, congenital by birth, there is deformity in ankle and foot. What are those deformities? That is equinovarus. Is that clear? These two are very important. Equinus and varus deformity is very, very important. So that is the meaning of your CTEV. And how do you remember the various deformities? Cavus, adduction, varus, and equinus. So why actually all these happen? These all happen because there is abnormality in the posterior and medial structures. So the main problem will start in the talus. So this talus is considered as your culprit. So talus is the main person who starts all this drama in the CTV, right? So he will not be in his position. Because he is not in his position, the calcaneum gets affected. Because the calcaneum gets affected, all the ligaments on the posterior and medial structures, now what happened? They get contracted. So because of that contractions, they developed equinus and they go into varus. So that is actually the story of your CTEV. So that is a deformity which is identified at the birth. So now questions. So again, 1 in 1,000 live births. 1 in 1,000 live births, CTEV is seen, right? Usually it is unilateral, but sometimes it is also bilateral, right? Associated symptoms could be torticollis, metatarsus, adductus, and your DDH. So sometimes it gets spina bifida. These are all the associated symptoms which can be present along with CTEV. So you have to check for it, right? And now, how do you treat it? Treatment, serial casing. So how do you do this? What is the technique we use? Serial casing. Start right from the first week of birth. What is the technique? Name of the technique which we use for serial casing? Very good. Ponseti. So this man Ponseti, before Ponseti has done something to CTB, there is one man called 𝐿𝐻𝐿𝐻𝐿𝐻𝐻𝐻 So 𝐿𝐻𝐻𝐿𝐻𝐻 method we used to use, which it was not so good. Now Ponseti has extensively researched and done an extensive serial casing, and he has shown to the world that CTEV is curable only with casing. Right, so you have to thank Ponseti. He has developed this excellent method which is reproducible, like anybody else also can do, right? So the order again is, we know, very, very important question for us. So order of Ponseti is cave, right? So once this casing is done, then the patient is put in this DB splint, right? So this splint is used for like 1 year. And after this splint, you go for CTEV juice, right? So this is the treatment part. So whatever you do serial casing, you correct it. First you correct the cavus, then you correct the adduction, then you correct the varus, then you correct the equinus, right? Then once it is corrected, you feel that the feet are neutral, then you put it in the DB splint for maintenance, at least for 6 months to 1 year. Right? And then you put the patient into CTEV shoes. Once he starts walking, then you use the CTEV shoes. So this is about the DB splint. So you see, this is the abduction bar. Again, it is also put in abduction only. Abduction and slight external rotation. So this is called the abduction bar. Even your Pavlik harness, if you remember, that is also in abduction. Okay. So this is about the CTEV. Okay. Yes, very good. Then what is this? Yes. What is this? Arbidance node, MTG, you can see some node there. This is your mallet finger. What is mallet finger? Swan neck deformity. I expected this. Yeah, it looks like swan neck deformity only, but it is mallet finger. So what is the difference between swan neck deformity and mallet finger? Why are you deleting? It's okay. Let us understand why it is not swan neck, why it is mallet. Cricketers. FDP tendon rupture. Okay. If flexion tendon is ruptured, why it is going into flexion? Right, Rajan? If your flexion tendon, so this flexion tendon is on this side, right? So if the flexion tendon is ruptured here, who is pulling it into flexion? So it should actually be what? It should actually be extensor tendon rupture, right? Now because this extensor tendon is ruptured, the FDP is pulling it into flexion. Yes, very good. No sorries. No sorry. Just you have to learn. That's it. Only thank you. No sorry. So this is a distal phalanx injury. Right? So usually what happens is, as Rajan has told us, there will be an extensor tendon rupture. Because of that, the finger goes into flexion. And this could sometimes be a avulsion fracture also. Avulsion fracture of the distal phalanx, right? So if you see, this is your distal phalanx, distal middle, right? So this is your distal phalanx. And here will be, this is the base. At the base will be attachment of your extensor tendon. And here will be your flexor digitorum profundus tendon. I'm talking about distal phalanx, right? And whenever there is a rupture or avulsion fracture of this extensor tendon, this will result in mallet finger. And whenever there is a rupture in FTP, this will result in jersey finger. Done? Clear? Very good, Gautam. Yes. Jersey finger. So extensor is mallet finger. FDP, flexor digitorum profundus, is jersey finger. Just remember this much. Very, very important, because this has been asked like a match the following in the previous exam. So they have put all these fingers, mallet finger, jersey finger, swan neck deformity, botanist deformity. Coming to swan neck deformity, yes, you are right. There is a flexion at DIP, but remember, there should be a hyperextension at PIP. Here there is no problem at PIP, right? There is only a problem which you can see in the DIP, right? This is only the problem. There is no hyperextension which you can see in the PIP, right? So swan neck deformity is flexion at DIP, hyperextension at PIP. Similarly, botanist deformity. Botanist is exactly opposite, where you have extension at DIP, flexion at PIP. So these four are being given as the match the following in INI-CET, right? So you have to remember mallet, jersey, swan neck, botanist. Opposite of swan, yes. Remember one, anything, either swan or botanist. Both are exactly opposite. Okay? Yes, very good. So these are about the various finger deformities, right? And this swan neck, and these are usually seen in your rheumatoid. Okay? What is this? Yes, Rajan, Gautam, MTG. Whereas Bharat gone, he left. Yes, very important X-ray. Very, very important topic. Yes, very good. So this is your anterior dislocation of a hip. Very good. What is the position? Attitude of the limb in anterior dislocation of hip? It is flexion, abduction, and external rotation. Faber. Okay? Fine. Yeah. It is not posterior dislocation, it is anterior dislocation of hip. So here what you see in the anterior dislocation of the hip, how do you not get confused, MPG? So here you see the lesser trochanter. So always rely on your lesser trochanter. If your lesser trochanter is prominent, then you go for anterior. Okay? And if your lesser trochanter is not seen, then it is posterior. Why? Because in anterior it is Faber, right? Faber, abduction and external rotation. So whenever you see external rotation, you happily can see the lesser trochanter. And posterior dislocation, it is farther. So farther is adduction, internal rotation. Internal rotation, you cannot see the lesser trochanter. Okay? That's it. Very, very important. And what is the important complication of this? So there will be injury to the vessel or the nerve. So femoral artery. If it is posterior, the most important thing you have to remember is, yes, vessel. Very good. In posterior, it is sciatic nerve. Yes, very good. Vessel. So femoral artery is on the anterior aspect. Now you can feel the pulsations also. Now because of the anterior dislocation, the femoral artery gets injured sometimes in the anterior dislocation of the hip. Is that clear? Very important. What is the immediate thing what you do for this? So you have to always immediately reduction. And this reduction is done under anesthesia. So reduction under anesthesia is the treatment. Any dislocation, either it is anterior or posterior. Okay, yes. What is a vascular sign of Narath? So what is vascular sign of Narath? So this is an important sign. So usually what happens is whenever you want to feel the pulsations, what do? So now I'm feeling the radial pulsations here. So whenever I want to feel the radial pulsations, what I do, I press the radial artery around a bone, right? And then I block on the proximal and the distal side. And now I feel the pulsations with my middle finger, right? That is 3-finger technique. Similarly, femoral artery pulsations are felt by putting pressure over the femoral head. So whenever the head is dislocated, you cannot feel the pulsations. Head is not there in that position, so you cannot feel the pulsations. So you will tell that vascular sign of Narath is positive, right? That means you cannot feel the pulsations, but artery is intact. Only thing is, because the head is dislocated, you cannot feel the femoral artery over the femoral neck or head, or IC fractures sometimes. So there you cannot feel the femoral artery pulsation. So whenever it is pulsations absent, it is vascular sign of Narath positive. Clear? Sriraj? So these pulsations are not felt. Okay, so that is your vascular sign of Narath. Good. What is this then? So this is a swelling or a deformity seen in your emergency department. Yes, very good. It is a dinner fork deformity. Where it is seen? So one of the most important, commonly seen in post-menopausal women. Yes. It is an indicator of osteoporosis. Yes, this is an �'𝐿𝐼's fracture. But what was the question asked? So this image was given in the exam and the question was asked A, B, C, D. Wrist fracture, intra-articular, wrist fracture, extra-articular, right? Is it a forearm fracture or a hand fracture? That means carpal bone fracture. So this was the options. So what is the answer? A, B, C, D. What is the answer? Is it a wrist fracture, intra-articular or extra-articular, a forearm fracture or a hand carpal bone fracture? Yes, the answer is, it is an extra-articular fracture. So the answer is B. It is an extra-articular, the 𝐒𝐿𝐼's fracture. So 𝐒𝐿𝐼's fracture is an extra-articular fracture. What is the displacement which we see? It is a dorsal displacement, right? So whenever you see an extra-articular fracture with the dorsal displacement, the 𝐒𝐿𝐼's fracture, this is the deformity which we see, right? So this was exactly the question. This was the image which was given in the exam, and this is the question A, B, C, D. So this is the beauty of the INI-CET questions. You know, usually what we do, we try to learn it as 𝐒𝐿𝐼's fracture, but the concept behind it. Whenever it is an extra articular fracture with a dorsal displacement, you will see a dinner fork deformity, right? And then the answer is the extra articular fracture, right? So that is how you have to prepare for the exam. You have to, small minute details also you have to remember, right, regarding that particular concept. Yes, the cast is handshaking cast, that is fine. But what is this step? What are the steps? How do you put the cast? So first you give the traction, then after traction what you do? Handshaking. Yes, traction you give. Then what is the maneuver? Pronation, huh? Then so hand pronation you do, then you go for palmar flexion, and then you ulnar, yes, ulnar deviation. Then you apply the cast. Which is that cast? It is called the Foley's cast. So palmar flexion and ulnar deviation. Traction, palmar flexion, ulnar deviation. Then you correct the displacement, right? Give pressure over the dorsal side so that the distal fragment goes inside, and then you give your Foley's cast. So that is a treatment for your Foley's fracture. Is that clear? Good. What is this? Yes. So the question for this is, ring sequestrum seen in. Yeah, this is sequestrum, correct? But where do you see a ring sequestrum? So the answer is pin tract infections. Right? Yes, very good, Gautam. Pin tract infection. So that was exactly the question. Elizarov, pin tract infection. So ring sequestrum was the question which was asked. So why did I put this X-ray? So this X-ray they have given. Mainly they like to give image-based questions in case of infections, especially your chronic osteomyelitis. So what is important here? You see that there is a dead bone surrounded by granulation tissue, right? So that is seen as lucency, right? So you have to look for these things in the exam. So they can just put up this X-ray. So this X-ray is very much identifiable, right? Everybody can identify, but they cannot give you the same X-ray, right? Sometimes they give X-rays which you can't understand them properly. So that time you have to take little time and you have to identify that what they're actually asking you about. So if you see, there is a dead bone which is inside and it is surrounded by the lucency, which is called as the granulation tissue. So this is the sequestrum, right? So this is the sequestrum, and you see there is this particular part from here to here, the bone, if you see, it is not differentiated into cortex and medulla. It has become very thick bone. You see, this is all thick. So here, if you see, this is cortex, this is medulla, right? So here the differentiation is lost. So this is the one of the important things for infections, what you have to look for. The bone has become thick like that, okay? And here you see there is an increase in the lucency. So these are all the things which you have to differentiate between tumor and infection. So usually they put the X-rays. So they want to identify the X-rays between tumor and the infection. So you have to be very, very important. So the periosteal reactions are very important for tumors, right? And this corticomedullary differentiation. You have to look, right, for infections, right? So as you all know, the sequestrum is dead bone, involucrum is the new bone, cloaca is the openings over the bone, right? So this is about the infections mainly. You have to, mainly I want you all to keep in the mind that X-rays, whenever they put, you have to differentiate between tumor and the infection. So if the bone is not very good, look for first periosteal reaction. If there is no much of periosteal reactions, if the corticomedullary differentiation is not much, you see some amount of traces of lucency, then usually you mark it as infections. But there is some periosteal reactions, like for example Ewing sarcoma or osteosarcoma, so you have to go for tumors. Okay, this is how you have to the X-ray. This is an IT fracture, right? So you will see there is a fracture here. So this is the greater trochanter. If you remember, this is the lesser trochanter, and the fracture is extending between GT and LT, which is called as the intertrochanteric fracture. And what is the what do they ask about is, they ask you the treatment for it. So whenever it is an IT fracture, you either go with two important things. One is DHS and the second one is PFN, right? So you're going to do nailing for IT fracture. Yes, DHS is dynamic hip screw, PFN is proximal femoral nailing. So this is your DHS, that is dynamic hip screw. This is your PFN, proximal femoral nailing. So treatment of IT fracture is nailing, whatever may be your age of the patient. So usually we see above 65 years, right? And complication of this is, it goes into malunion. And because it is an extracapsular fracture, you see the lateral border completely touching the couch. So these are all the words which they might ask you. So they might ask you, a patient has been, Evans classification, okay. The patient has come with the pain in the hip joint, and they will not give you the image, and they can put up these words such as extracapsular fracture, lateral border of the foot touching the couch. And now what would be the treatment for it? Always remember, IT fracture, the treatment is nailing. Either it is a DHS or a PFN. Is that clear? MTG, where have you gone? Okay, now once we are done with IT fracture, there is friend of IT, right? That is your IC fracture. So IC fracture is your intracapsular fracture, right? So what are the classifications name? We have very important Garden, anatomical, and your Powell's. And what is the most important complication? Non-union, and very, very important, avascular necrosis of femoral head. Yes, very good, Gautam. NEET UG 2027. Prashant. We'll connect later, Prashant. This is for NEET PG, what we are discussing. So NEET UG is far away from our discussion. So these are the complications, right? So non-union and avascular necrosis are two important complications of the femoral head, that is IC fracture, which you have to remember, right? And now, how do you treat this? This is very important. Treatment of IC fracture. So this depends upon the age. Now you see, if the patient is less than 45 years, you can go for CC screws, right? And more than, okay, 65, okay, more than 45 or more than 50, you have to go for a very, very important surgery, ME arthroplasty, right? And if the patient have some acetabular involvement, such as acetabular is already in trouble, then you can directly go for total hip replacement. So these are the various options you have to put in mind: CC screws, hemiarthroplasty, THR. Yes, very good. So what is this? What is A? What is B? So this is the fracture. This is the IC fracture. And that is your IT fracture. IC fracture and IT fracture. IC fracture is, you have three options. That is your CC screws, hemiarthroplasty, and your THR. So CC screws is mainly for the young individuals. So CC screws is mainly for the young individuals, and this is also called as osteosynthesis, which is achieved by your CC screw. So three screws we place. Then what is this? This is your hemiarthroplasty. What do you mean by arthroplasty? Yes, arthroplasty is nothing but your replacement. Hemi matlab half. So whenever you're replacing only the femoral head by prosthesis. So what are the important prosthesis? This prosthesis is called bipolar. There are two other prosthesis, Moore's and Thompson's also. But now we are into bipolar. So this is your bipolar. And what is this? This is THR. That means total hip replacement. So where do you do this total hip replacement? Where you are replacing the acetabulum also. So hip joint, acetabulum plus femoral head, right? So THR is femoral head plus acetabulum. That is this. If you see these two, this is the acetabular cup, right? There is no cup here. It is only bipolar. So this is hemiarthroplasty. That is, yeah, Moore's, there will be two holes. Sometimes these holes cannot be seen on the X-ray, but Thompson's you can identify on the X-ray. You will have extra neck. So Thompson's will be like this. This is the head and they will be like this, some extra neck. And then you have your stem. Okay, so Thompson is this neck. Whenever you have this extra neck on the X-ray, you can see, you can identify Thompson. Moods you can identify as if the holes are still not present, if the holes are not closed up, you know, by the bone or the cement, you can see the holes, or else you can't identify. But Thompson, you can identify the neck. But this is your bipolar. Okay, bipolar, if you see, the stem is like this, very sleek stem, right? And there is no neck or something like that. You know, this is bipolar. This is your bipolar prosthesis. Okay, is that clear? Remember, Moore's with two holes, okay? And Thompson with the neck, extra neck we have in Thompson. Okay, now what is this? Yeah, final one. What is this? So this is ivory vertebrae. Yeah, very good. Where you see ivory vertebrae? Yeah, very good. So now let's have few words about the most interesting Paget's disease. So what is a Paget's disease? It is seen usually in the elderly, right? And this is some abnormality where the bone architecture is disturbed. Yes. What happens to the bone? What happens is the basic problem here, what happens is the bone turnover, what we called as the bone turnover, increases. That means you have to remember alkaline phosphatase increases. This is the only thing which you have to remember. Okay, so bone turnover increases, the alkaline phosphatase increases. There will be both increase in blastic activity and increase in the clastic activity. This might occur in phases, but the bone is abnormal. This is what you have to remember. And why it is happening? This can happen because of genetics, because of virus, or because of mutations. Right? So these are the reasons why it occurs, right? So sometimes there could be a genetic involvement, there could be some virus, or there could be some mutations which are happening in the genes, mainly in the bone osteoclast, right? And now the bone becomes abnormal, and you will see that there is an osteosclerosis. Yes, it could be pre-malignant also sometimes. It could be pre-malignant also. There is evidence of development of sarcoma. Okay? But usually patients come with pathological fractures because the bone is abnormal. And what are all the signs you can see here? Increased sclerosis, the picture frame vertebrae, right? The ivory vertebrae, right? And osteoporosis circumscripta, right? Yes. And osteitis, yeah, cotton wool skull, and skull becomes big in size. And because of the sclerosis, patient may develop deafness. That is again otosclerosis, and patient may develop deafness. And sometimes in the spine, they will develop lumbar stenosis, right? Right, so these are all the things which you can see in Paget's disease, right? So they will have ivory vertebrae, picture frame vertebrae, and cotton wool appearance of the skull, right? And then they can develop deafness, otosclerosis, lumbar stenosis. Okay, what is the one abnormality which you have to remember? Increase in ALP. Rest all will be normal because of the increase in blastic activity. Alkaline phosphatase increases because there is an increase in blastic activity, right? And how do you treat it? Treatment, usually we treat with zoledric acid, IV zoledric acid, right? And sometimes with the surgical fixation, right? So that is the treatment. Yeah, you can give bisphosphonates also, but usually we give the zoledric acid first for the treatment of Paget's, where patient responds well, and then you can put on bisphosphonate. Okay, so that is about the Paget's disease. So what they will ask you mainly is what is the biomarker for this. The most important thing is increase in ALP. Rest all is normal, right? Rest all is normal. The calcium, the phosphorus levels, rest are all normal. Vitamin D is normal, but the only thing is there will be an increased ALP, and the patient might just tell you that there is an just increase in the skull size, or there could be only deafness, or there could be only pain in the spine because of lumbar stenosis. right? And then you will take the x-ray and you can find the picture frame vertebrae, the cotton wool appearance, right? And sometimes rugged jersey spine also can be seen, right? So these are all the things for Paget's disease. What is the abnormality? The abnormality is both in the osteoclast and the osteoblast. There will be increase in the blastic activity and there will be increase in the clastic activity, and they will disturb the bone architecture where the bone becomes brittle. And because of this brittleness, it will result in pathological fractures. Okay, so that is about your Paget's disease. Okay, so that completes the session for today. And what I have not completed is, yeah, complication is that only. They can develop pathological fractures. They can land up in sarcomas. So these are the complications of Paget's disease, right? Yes. So you have to have a look over nerve injuries also. Like they can put up the pen test, book test. I know these have been revised wisely for you. So I have not put those x-rays, okay? So nerve injuries you have to revise, okay? So that's it for today's session. Anything, any doubts you have? Yeah, even I missed you, MTG. You vanished in between. Thank you. Thank you, Gautam. Thank you, Vidya. Thank you, MTG. So any doubts you have, any topic you want me to repeat, or so we are always available for you. This is my Insta ID, Dr. Alekhya Ortho, and PW MedEd is there for you. We are available on Telegram as well. So you can put all your queries there. We will get back with the answers. Hope the session has brought few, important points into your mind so that you will not miss in the exam. Hope you all do well and come up with the smiling faces for the recall. Okay? See you all. Bye. Thank you so much. This will be available. The PDF will be given for you in the Telegram channel. For the PDF, you have to come to our Telegram group. Okay? And there you can access the PDF. Thank you. Bye.